Good evening, doctors, and welcome to the Quirón Salud Masterclass. Today we have the pleasure to introduce you Dr. Gerard Conesa. Dr. Conesa is the head of the Neurosurgery Department at the Teknon Medical Center. He was the first neurosurgeon in Spain to operate on a patient affected with a brain tumor while he was awake, and he was also the first to use robotics in neurosurgery. His interest in mapping and monitoring motor and language function in patients with brain tumors centered his thesis and has accompanied him throughout his long professional career. Dr. Conesa is also professor of neurosurgery at the University of Barcelona and has published numerous studies in prestigious scientific publications. 3 quick instructions for you, doctors. The questions to Dr. Conesa can be typed in the questions and answer box. Some questions will be answered by the doctor at the end of the session, and the certificate of attendance can be collected at the end of the session. Please, Dr. Conesa, you can proceed to present the webinar. Okay. Thank you very much.
Thanks very much, Carlos. Well, I was saying that thanks for inviting me, Carlos, to the masterclass, and I'm very pleased to be with you today. Especially with a topic which I am quite comfortable because I think it's a very, very interesting topic, and it gives you a lot of clues about the brain tumors, especially gliomas that are in the brain, as you know, and not something pushing the brain, but inside the brain, and then the issue of functions inside the brain, how to preserve it. It's been a motor for my career all through the years. So I've thought about giving you examples instead of giving you the theory, which I will just go through quite quickly. So if you see the picture here, we see this type of, for example, this insular glioma, no, that we have here on the left side, or you have this premotor glioma, which is just anterior to the motor strip, and this is the type of situation in which neurosurgeons we find quite frequently, and we have to deal with function. So when I started doing this brain mapping, that was in 1989, quite long ago, all of them we operated on them awake because we didn't have all the developments that we've had later on. And now the only patients that we operate awake are the patients that need to be talking during the operation. So on the left side, it would be a patient that is also a patient which is on the as you can see, on the left side. So that would be certainly a patient to be awake. And on the right side, nowadays, we would operate the patient asleep. When we say awake, the anesthesiologists have been changing the technique, and now we are usually using the asleep, awake, and then asleep again technique, so that the patient does not need to be awake all the time of the operation. That is really very tiring for the patient. And the collaboration is not very good at the last time, and it's not necessary. So that's the way we do it now. I'd like to talk a little bit about language. Language, as you know, is a very complex function in which you have to understand, you have to repeat, you have to deal with semantics, with phonetics, with rhythm of prosodic of the conversation, grammar. So there are a lot of things when we are talking about language. We are involving really a lot of different issues. And I'd like to review a little bit, for example, the Broca's area. Broca's area, which is a concept that came in the late 19th century. As you remember, Broca is on the third frontal gyrus, and we all think about Broca, about an area in which language is produced. That's the classical concept from Broca. But I'd like you to see this cadaveric study in which different areas, as many as 11 different areas, can be mapped out when you study the what type of biochemistry is implied in the neurotransmitters. So this is really different, not only from the Brodmann areas, from the histology, but also on the connectivity and also on the neurotransmitters. So this is much more complex than the classical concept that we have. I'd like also to talk a little bit about the functional MRI. We use functional MRI. We started with functional MRI in the 90s, at the beginning of this technique, and we published several papers about it. And what I'd like to say about functional MRI is that it is useful for lateralizing language, but it's not really useful to localize and to guide the surgeon during the operation. That is something we can discuss afterwards, but that's my statement. And why? Because functional MRI, you know, it's using the coupling of hemoglobin and the use of this hemoglobin when it is activated one of the areas. So there's more oxyhemoglobin or deoxyhemoglobin, and this has different signal in the MRI. So if you make a statistical difference between one and the other, you see these activated areas that is really statistical treatment of the image. What this means is that these areas are participating in the function, but not necessarily if you take them away, the patient is going to be without this function. That is something I would like to say about functional MRI. We can talk a little bit later afterwards. And using these functional MRIs, I would also like to say that there are like 3 categories in how we can manage function from a neurosurgical point of view. So you have this type of studies in which you are seeing participating areas, which mean that they are indeed participating but not are essential. There's another one in which patients need these areas to do this function at this time. This would be necessary areas. And there's another ones in which if you take them away, the patient will never recover from a problem of language or from a problem of a motor problem, a sensory problem. These are the essential areas. And I'll come back to that a little bit later on. Here, for example, we have these typical motor alternating movements. This, as you can see, it activates the perirolandic areas around the sensory motor cortex, but also there is on the left side, on the right side of this brain, activation in the supplementary motor area. And the tumor, as you can see, there's this black dot on the other side, on the left side. So with this, what we can think is if the patient has transferred the activation of the SMA to the other side because of the tumor or not. That would be another application for functional MRI. And that is the combination of going into the OR, doing the stimulation during awake procedures, and then seeing the activation in the MRI. So the red dots would be for language, SMA. The second dot would be for motor SMA movements. These alternate movements, for example, is one of the tasks that we use. And you can see on the left side, on red, it's the motor strip. On blue is the motor strip. And this is the activation areas, which is very, very similar, but not exactly on the same place where the fMRI shows you the activation. So we are using the patient being awake. We're using the stimulation mapping, And we are using this for guiding surgery, not the functional MRI. How does the stimulation, the electrical mapping stimulation works? For example, you can have a positive response to an electrical stimulation. So you give a very short and very low amplitude milliamperage to spots in the cortex, and then you can map, for example, in these numbers, you map different muscle groups doing different, for example, flexion of the hand, extension of the hand, and you can go and put a ticket on attack, I mean, not a ticket, attack on the cortex, and then you go and you map, so you know where these functions are. The other way, for example, for language, and in this case, a number in yellow 1 and 2, what we are doing here is this, say to the patient in the operating room, do this type of task, alternate task, and when you stimulate there, you can stop the task that he's doing. So when you stimulate, what you do is like a virtual lesion of this area, because you are taking it away from the equation, out of the activation with the stimulation. So the patient cannot do it because this part, this small mosaic of the cortex is not working properly, because you are stimulating it, you are taking it away of the circuitry. And then you can map this type of functions. The same with language. You can do the patient, do, for example, naming, or you can do naming nouns, naming verbs, repeating. And when you stimulate and the patient is not able to do the task that you are asking for, this means that this area that you're stimulating is part of the essential, we call essential sites, because we thought, I think I will show you some problems with this naming of essential, because sometimes it could be unnecessary, but it could recover. That is another of the things that we are using for our surgeries. This is the tractography. This is the way in which the arcuate fasciculus puts together the Broca, the classical Broca, with Wernicke's territory, with the areas. And it also goes to Gershwin territory in the parieto-temporal. And this is being more and more used in our surgeries, because it gives you an idea of the distortion that the communication between areas is having. And I'll try to show you several cases. So we are on the theater, and we try to take out and how we do the decisions. This is a case in which you can see in orange how the tumor is depicted in the 3D image of the brain on the left side, and you see these tags. You see how there are two gyros that are sensory and motor strips that are being pushed anteriorly, and this is a tumor that you have to be dealing with the posterior. It's posterior to the sensory area, so when you go deep, you can have a problem with the sensory or even with the motor area. So what you do is you can take away this part of the superior parietal lobe, but when you go deep, you need to know exactly where the sensory motor strips are, and especially when you go deep, there's no pile surface that's going to make a border for you, and down there, with the distortion of the tumor, you need some guidance to be able to take out all the tumor possible and not taking away function. So this is done with stimulation, with the patient asleep, fully asleep, and you stimulate, and then you just follow where the tracks, where the motor track and the sensory track are going down, and then you have to stop when the milliamperes are like 3 milliamperes. Every time you have to stimulate on the deep of the sulci in the subcortical matter, 1 milliampere means 1 millimeter in function approximately. So we usually use the 5 milliamperes. We don't get closer to that, because if you get closer, you can have problems with postoperative function. That is a little bit more anterior. In this case, we can see how this xanthoastrocytoma is really inside of the sensory strip, and also on the back of the sensory strip, on the parietal lobe. This is a jeweler, and when we went dealing inside of this sensory strip, we found that there was no function at all inside. So probably the patient had gone some plasticity inside of the sensory strip, so that could be taken and removed completely in this case. It could be the case that this had not been like that. So if you take out part of the hand or part of the leg, you will have certainly bad recovery. Even in the sensory strip, you will have a patient that will have movements which are not well tuned and well coordinated. That is another case. Also on the sensory strip, you see this enormous tumor just in front of the number 3 on blue. This 3 means motor strip in this case, and this is on the sensory strip. And as you can see, there's no we cannot elicit any sensory feeling or the patient is awake in this case, and this we could take that out. On number 1 on red, this is the hand. If you are going inside the hand, as I said, you're going to have a permanent deficit. So we never go to the hand, but we can take out the motor and the sensory strip on the head, on the face, on the orofaciolingual, because except for sometimes you can have some swallowing problems. We've had some inferior facial palsy, very, very mild, and it improves with the days or the weeks. So that you can do it. That is another case. That is the removal of that case, as you can see, the one that I was showing you. And this is another case. That's a case in which we can see here, like the tumor is in what we call the omega of the motor strip. The omega usually is related to the hand motor area. In this case, there was also plasticity inside of the motor strip, so that this patient that had been already operated in another center, we could go inside and do this type of mapping in which number 4 is related to the face area. So, as I said, you can take that out too. So this is the situation after surgery. So you can take this part of the face, and in this particular case, where usually we would see the hand, it was taken by a change in the plasticity, and it was clearly more superior to the usual place. So until you are on the operating room, there is no test that can really compare to going there and doing the mapping and have the patient awake sometimes with just with a neurophysiologist. So now this is a case in which I placed the opposite way, so you can see these pictures down as they are showed in the 3D MRI with the craneotomy done in the MRI, so you can orient yourselves. This is clearly on the Broca's area, on the proper Broca's area, and on the opercular side of the third frontal convolution, which usually, when you stimulate there, you usually have anomia. So you say the patient, keep going with saying sentences that you show or saying names, and the patient, when you elicit the stimulation on this, when you do the stimulation on this area, there's usually some places, some tags that you have to place down there. But in this case, as you can see, the Broca's area has no stimulation, so we can take out this area that you saw, as you can see here on the right-hand side. There's another thing in this patient. As you can see, there are different languages that he speaks. You can see the flags there. It's Catalan and Spanish flags. So we see that most of the places there are both languages on the same site, but there's one Spanish flag which is alone, and this is the second language of this patient, and that's quite usual in bilinguals, that the second language has a little bit bigger the area, the surface that uses, so it's like a less efficient way of organizing the cortex for the second language than for the first. That's another case. For example, in this case, you see this tag number 5. It's on Broca's area, so we can also take that out because there was no stimulation being elicited by the map. So we kept going and we could take that out. Maybe I would like to show you some cases. This is one of the cases with bilinguals, and what I told you, that the Spanish flags in this case were different than the places where we could elicit both languages, and this is the usual pattern that we find, but there are, of course, times in which we find, for example, a first language that is also alone as a cortical resource, and that is clearly the more usual pattern. I would say the most usual pattern, 70% of the times, is that the map is exactly the same. But when you have it different, this is much more usual, being with the second language a little bit more bigger cortex that is needed. This is another case in which we mapped 4 languages, and you can see that there are, in this case, some moments in which you have a British flag, a Union Jack, alone, and you have in the Basque Country, that's the flag for the Basque Country. That was a case that was sent to us from there. And there are also different flags for Spanish flags. So as you can see, we have a lot of diversity in our country. And that's a case that I wanted to place because, and then I will finish, I think, with this. I'll go to the questions. This is a case in which, as you can see down there, there's like a ring on, and there's a Spanish flag in the inside of the ring. All right, this patient spoke 2 languages. We always speak with the patients before going to the operating room, and we tell them there could be a case in which we could find that we can preserve one of the languages and take the tumor out. Would you want to do that, or you want us to spare both languages, or all the languages that the patient is speaking? And in this particular patient, he told us, I want to speak Catalan. I don't mind not speaking Spanish. So that is the situation that we had in the operating room. The tumor by neuronavigation, as you can see right there, is very near to Broca's area, and we mapped a Spanish flag. So when we started taking that out, as you can see, we took it out, all of it. We went through this Spanish flag, and the patient stopped speaking Spanish, but he could keep on going with Catalan. So that was what we agreed before the operation, so we kept on going. And remember what I was saying at the beginning about categorizing the language from our neurosurgical standpoint. and we talked that there was tests like functional MRI in which you could see activation areas, but very many times we take out these activation areas and nothing's happening because we trust this type of maps, not the other one, for making resections, not for other things, but for making resections. And the other category would be necessary. So we are sure that this is necessary, these areas in which the flags are placed for language, because when you take them out by stimulating them, the patient cannot do the task, cannot speak. So these are necessary. But we never take out these language areas. And that's why we call them essential language areas, or how they are being called. But this patient, 6 weeks after not being able to speak Catalan, after having removed that, again spoke on both languages. So this means that we never know if they are really essential, because there could be, we're never taking out those language sites. We do that to preserve them. But in very, very peculiar cases, as this one, I have to say I didn't have this type of case any other time. So in this case, this patient recovered, so it was not that essential. If it had not recovered, it would be essential. So I think that is very important for our idea of how to deal. And I think, do you think, Carlos, I could keep going? Is that enough?
5 minutes, 5 more.
Still more? All right. Okay. So I will show you another case which also tells us a lot about lateralization of language. As I said at the beginning, I really trust lateralizing language. We do that quite a lot with functional MRI in epilepsy cases, for example, epilepsy surgery cases. But in this case, we had a tumor which was a glioblastoma. This glioblastoma was on the right side, as you can see. And this patient had problems with language, with the seizures. So we thought that language could be on the right side, even that this patient was ambidextrous. We had this type of functional MRI with language in which, we decided to operate on him awake, even that was on the non-dominant side, on the right side. But since this patient had problems with language, we thought that there could be a problem with language after resecting it. So that is the case. In this case, M means motor strip. The T is where the tumor was. So this tumor was on the motor strip and was also on the language. The S means Sylvius on this vein, and S here means sensory. So tumor is quite extensive on the motor strip near the orofacial lingual, and we found these blue dots, which are language sites. So we could only take a small part of the tumor. We could not take the whole tumor. The interesting part of this patient is that the patient, after 1 year or so, he started developing again the tumor after radiotherapy. And in this case, the functional MRI showed clearly, because we did several functional MRIs, that the patient started having the tumor again, but did not have these problems with languages. And functional MRI showed how all the function lateralized to the left side, which in an ambidextrous patient could probably be the more frequent thing. But in this case, we had this mapping that showed that we could elicit language problems on the right side, and an MRI that was ambiguous but finished at the end, being completely on the left side, which is the usual one. All right, thanks for your attention up to now.
Thanks so much, Dr. Gerard Conesa. It was such an interesting presentation. Thank you very much. We have some questions for you. The first one is, how many languages have been mapped in a patient that you have operated?
That I have operated, it was this case that I showed that was for languages. For languages, the patient was already quite tired at the end of this mapping and resection and being continuously changing languages and monitoring not to be a problem during the resection with all of them. But one of my colleagues had a patient that he mapped 11 languages. 11 so that's a record as far as I know. So I don't have the picture, but I have to ask him to give it to me, because I'm sure that's the record.
Okay, another question. In your experience, if a patient has 4 languages,
yes,
how many languages can be retained? All of them, or?
Well, you have to talk to the patient in advance, because you can have this type of situation in the operating room. So you need to know, okay, this patient needs to keep on going. For example, I have a patient I have to operate in the near future that she's a teacher for English language, and that is so important for her that she's very reluctant to being operated. She has a tumor that I'm following her for years, and now it's growing, so we will have to do something. But she's been very reluctant to go to the operating room. In this type of case that I showed, that's a very peculiar case in which the patient says, no, I prefer not to speak one of the languages. That could be, for example, for languages that are so hard to learn, no? And then you can have a problem like that. But of course, always languages which are not your vehicular language, your usual language, no? So we try to retain all of them. That's what we do.
Another question, doctor. What can possibly go wrong in this kind of surgery?
Well, everything can go wrong, no? Yeah. I mean, these are complex surgeries in the sense of decision, and you have to make a balance between it's what we call the oncofunctional balance. You want to take as much tumor as you may, and you want to preserve function. I would like to say that I've always, when you've had an issue with leaving tumor behind or leaving function behind, I've always wanted to leave tumor behind and make the patient keep going with as much as, because sometimes patients are not really understanding what it can be. So this pre-conversation, this previous conversation, and knowing not having language is really something very, very hard and very, very important. So.
Very interesting, doctor. Another question: the plasticity of language might change from one hemisphere to another? Yeah,
that's something that we see, for example, in epilepsy surgery, in cases in which we do hemispherotomies. Usually, if the patient has been younger than 6 years, that he has started the seizures, these patients usually have transferred the language to the opposite side, from left to the right side. So you can do a Wada Test. What is called the Wada Test means that you anesthetize only one hemisphere. The catheter is placed on the carotid, and it only goes to one of the hemispheres. And you check if it is anesthetized and the patient keeps going with language. This means that the patient will tolerate well the hemispherotomy. So this type of transfer is very usual in younger patients, but it's not as usual as the one that I showed you in an adult patient. And that I'm not aware of very many cases that are able to be showed this transfer.
Another question, please. What's the best prognosis you experienced in doing such surgery?
We started this surgery in 1989. I learned that from George Ogeman in Seattle. And there are some patients from maybe 20 years that are still without having a relapse of the tumor, even in some malignant tumors. In fact, we are now collecting, because it's not that me that we have. I have some of them, and there are some other doctors in Barcelona that also have some very long-standing malignant gliomas cases. And there's a tendency in the oncology in the last years to be aware of these very long survivors, and then try to make a genetic study on what are the prognostic factors, what do they do, and try to go with this. So anything can go wrong, but sometimes things go unbelievably well. Absolutely. which is not the for malignant tumors, not the usual case.
Perfect. And another question, the last one: how many days of recovery does a patient need? For example, when does the patient have the option to do normal life, or to travel back if it's an international patient, for example?
Yeah, when you deal with this type of tumors, with insular tumors, with very eloquent areas tumors, this oncofunctional balance, if you really are very close to the function, in my experience, in my series, I've operated around 700 of these cases. 70% they experience a problem in the immediate postoperative phase. This is because you are really close to the function, and the edema makes that the patient has a problem. But when you go 6 weeks after this, only 4% of these patients that have experienced a problem are really worse than what they were at the beginning. So usually, in 1 week, the patient is out of the hospital, and depending on how deep this problem is, how close you've been to the function, it will take maybe 2 or 3 more weeks to recover completely.
Really interesting. And another one that just arrived here, how about in Parkinson patients' surgical procedure?
Well, that's another really different issue, but of course it's been neuromodulation not only in Parkinson's, but in depression, in other psychiatric problems, with tremor, with this is a very usual operation, and really very exciting results for years. It's something it's like a theater, no? That you put on with the battery on or the battery off, the patient changes really a lot. That's a very interesting operation too.
Very interesting presentation, Dr. Conesa. Thank you very much. Thanks.
Thanks to you.
Please, doctors, note that if you have more questions, you can put in contact with Dr. Conesa and team in the email Gerardo, which is GERARDO.Conesa, CONESA @gmail.com. Gerardo.conesa@gmail.com. And the next Quirón Salud Masterclass is going to be presented next December, the 15th, by Dr. David Arzamendi, Structural Heart Intervention Unit Director in Teknon Medical Center. Thank you very much for your attention. Bye-bye.